I now welcome Dr. P. Sushila, Madam, for Medical Termination of Pregnancy MTP Amendment 2021, Laws, Rules and Implications for Providers.
Madam, ma'am, shall I start the presentation?
Yes, ma'am. Yes, ma'am.
So I'll just share the screen and then I'll start. So good afternoon, and I welcome you all for this session on the respectful abortion care. It is a joint initiative of FOXI and WHO, and this is going to be in 4 sessions. First 4 modules to say. The first one would be on the amendments of the recent act, the second one on the medical and the surgical abortion, the third one is regarding the counseling part, pre-abortion, post-abortion, and also regarding the contraception, and the fourth one is regarding the respect what we ought to give to the women. So coming to the first module, which is on the medical termination of pregnancy, recent amendment Act 2021. So the objective of this module is to know what are the new laws and what are the changes that have been made in the rules. So as we all know, in 1971, the abortions have been legalized in India. This was mainly done to prevent the unsafe abortions in India, but still unsafe abortions are taking place, and then they are the major cause of mortality, morbidity, and they hamper the women and the girls' full participation. And 8% of the maternal deaths per year are due to the abortions, and it constitutes about the 3rd leading cause of the maternal mortality rate. Nearly 2/3 of the cases are being performed as unsafe abortions, and nearly half of the pregnancy-related deaths are in women and the girls under 24 years of age. So when is an abortion considered to be safe? So if the abortion is done by a trained person and by an appropriate method, it is considered to be safe. But if one of the criteria is not met, it becomes less safe, and if both criteria are not met, that is, it is not done by a trained person or by an appropriate method, it becomes unsafe. Apart from these 2 criteria, we also should know that it should be done in a certified place by the Government of India. And also we should know that it has to be done according to the gestational age. So we have to be, I abide by the law that we have to do within the permissible level of the gestational age. So Medical Termination of Pregnancy Amendment Act 2021 is a safe one, a comprehensive care which has been mandated by law. And what are the changes that have been made in this amendment? So we shall go through in the next 10 to 20 slides. The first one is regarding the modification in the requirement of the provider. So the requirement of the opinion of one RMP was up to 12 weeks in the previous act, and 2 provider opinion up to 12 to 20 weeks of gestation. But in 2021 amendment, opinion of one registered medical practitioner opinion up to 20 weeks of gestation, and opinion of 2 RMPs up to between 20 to 24 weeks of gestation. So why this change has been made? So this change has been made to increase the number of facilities, especially in the public sector like PHCs, eligible for the service provision till 20 weeks. That is in cases like where the PHCs only 1 RMP is there and they have to send to the either district hospitals or medical hospitals for the sake of the opinion. This change has been made to increase the accessibility and also the availability of the abortion services in the public, mainly in the public sector. And the second change that has been made is regarding the vulnerable group of women. So in previous act, MTP was only permissible up to 20 weeks, but it was permissible only up to 20 weeks, and beyond 20 weeks, we were only permitted to do it if we have to save the life of the pregnant woman. Otherwise, it was not permitted. But in the newer Act of 2021, the upper limit of gestation for vulnerable group of women has been increased from 20 to 24 weeks of gestation. And the further enhancement for birth with defects not compatible to life on medical board consensus has been increased. So this has been made to increase the access for the vulnerable group of women for safe and legal abortions, so that they do not go for an unsafe abortion. So this is regarding the vulnerable group of women. The third is regarding the modification for the birth defects and the congenital anomalies. In the previous act, it was only up till 20 weeks, but now the upper gestational limit does not apply in cases for the substantial fetal abnormalities diagnosed by the medical board. So there is no upper gestational limit if we diagnose it to be a fetal anomaly which is lethal, and the medical board gives it consensus. So why this has been done is to increase the access to safe and legal abortion services who seek services beyond the legal limit of termination of pregnancy with substantial fetal anomalies diagnosed late, or if the diagnosis has been missed, then they need not go to the court, but they can as well get it terminated with the consensus of the medical board. And the next one is regarding the marital status. In the previous act, the condition of the failure of the contraception was applicable only for the married woman and for husband. But in the newer act, the conditional failure of the contraception has been extended to any woman or her partner, that is irrespective of the marital status. Why this change has been made is to increase the access to the safe and legal abortion for any woman irrespective of the marriage age, especially with the upcoming changes in the legal age of marriage. And also we know that there is a lot of change in the socio-cultural and also the reproductive norms in the adolescents, and all this can be covered, and this is definitely an advancement for increasing access to the safe abortion. And the fifth change that has been done is insertion of the new clause for strengthening privacy. So in the previous act, the termination of pregnancy was like information should not be disclosed except under the authority of the law. But in the present act, neither the name nor any other particular can be disclosed. That is, we cannot write the name or any particular either on the OP card or IP card, and it cannot be revealed except to the person authorized by the law for the time being in force. So this increases the privacy, confidentiality of the abortion seeker and safeguards the rights and dignity of the women and provides unbiased free services, including the contraception and the counseling part. So these are the 5 changes that have been made in the newer law, and it prioritizes the confidentiality and the safety, and the name and other particulars of any woman seeking abortion to be confidential except to the person authorized in the law for the time being in force. And the ground of failure of contraception has been extended to the woman irrespective of the marital status. And the MTP Amendment 2021 Act defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks, and the norms regarding the RMPs and the power and the function of the medical boards. So who come under the vulnerable group category? So we all know that the MTP Act 1971 used to cover basically the conditions like danger to the life of the pregnant woman, or grave injury to the mental health of the woman, or grave injury to the physical health of the woman, or in case of minors, in case of rape survivors, in case of malformations and contraceptive failure. These were given in the 1971 Act. Now, some of them have been extended, have been brought from 20 to 24 weeks. That is the minors, rape survivors. So we can do the termination between 20 to 24 weeks. So survivors of the rape, sexual assault, incest, women with pregnancy in humanitarian settings, disaster or the emergency situations as declared by the government, change in marital status during the ongoing pregnancy, Fourth is women with physical disability, major disability as per the Disability Act. Fifth is the mentally ill woman, including mental retardation. Sixth is the minor. In case of the minor, the consent has been made very easy. That is, any person who is a major, irrespective of the parents, they can be a boyfriend, it can be like a relative who can support during the process of abortion, can sign the consent form. And the fetal malformations that have substantial risk of being incompatible with life, or if the child was born, it would suffer from physical or mental abnormality to be seriously handicapped. So these are the category of women, that is, all the 7 are called the vulnerable group, and we can perform MTP between 20 to 24 weeks. And we cannot like do a blanket abortion for each and every woman who's going to come to us for MTP. Only the 7 category we are allowed to perform MTP. So the rest, like contraceptive failure, physical injury, injury to the physical health, injury to the mental health, all this we can do only up till 20 weeks. So there is nothing like blanket abortion up till 24 weeks. It is only up till 20 weeks, and these 7 categories we can perform from 20 to 24 weeks. And what are all the norms for the registered medical practitioner? A registered medical practitioner is defined as one who has assisted 25 cases of medical termination of pregnancy and 5 done independently by them, or who have completed 6 months of house agency in the Department of Obstetrics and Gynecology, or a medical practitioner who holds a postgraduate degree or a diploma degree, or who has an experience not less than 1 year in the practice of obstetrics and gynecology, and 1 RMP opinion up to 20 weeks, 2 RMP opinion up from 20 to 24 weeks, and beyond 24 weeks, we need the consensus of the medical board. So under the newer act, the medical method of abortion has been brought under, and the RMP with experience in the practice of obstetrics and gynecology at any hospital for 3 months, or training with the performance of 10 cases of MTP by medical method of abortion under the supervision of a registered medical practitioner in a hospital established or maintained, or a training institute approved by the government. So here we can go ahead with the medical method of abortion. So 1 RMP opinion up to 20 weeks, same like 2 RMP opinion between 20 to 24 weeks, and beyond 24 weeks it is medical board opinion. So this is regarding the medical method of abortion, where minimum of 10 cases the RMP has to must have performed in a hospital under the supervision of a registered medical practitioner. So till 9 weeks. So experience at any hospital till 9 weeks, if medical abortion is performed, then the RMP should have conducted 10 cases under the supervision of an RMP. In case of surgical abortion, minimum of 25 cases of MTP and 5 done independently, or a medical practitioner who holds a degree or a diploma in OBG, or who has completed 6 months of house agency in obstetrics and gynecology, or a practitioner who has an experience in Department of Obstetrics and Gynecology and worked there not less than 1 year. So coming to till 12 weeks of gestation, so 25 cases of MTP done under the assistance of a registered medical practitioner, and 5 they must have done independently, a degree or a diploma holder in OBG, or a 6 months house agency in OBG, or worked in Department of OBG not less than 1 year, then they can perform the MTP up to 12 weeks. So between 12 and 20 weeks, a practitioner who holds a degree of OBG diploma or a degree, or a 6 months house agency in OBG department, or at least who have worked for 1 year in the Department of OBG, they can perform MTP. This is between 12 to 20 weeks. And beyond 20 to 24 weeks, it holds good for the same 3 classes of medical abortion, that is postgraduate degree or diploma, or 6 months of house agency, or who have worked not less than 1 year in Department of Obstetrics and Gynecology. But the thing is, opinion of 2 registered medical practitioners is required. And beyond 24 weeks, either postgraduate degree or diploma holder in obstetrics and gynecology, or a practitioner who has worked for at least 1 year in the Department of OBG, can go ahead with the medical termination of pregnancy. And again, the opinion of medical board is required, and the medical board takes all the takes into consideration and all the precautions, and also regarding the appropriate counseling, and also regarding the approved place, whether it is being done in an approved place, because the second trimester abortions are risky. So the medical board takes into consideration all the safety precautions regarding the women. So the gynecologist, a pediatrician, a radiologist, or a sonologist constitute the medical board. And the powers of the medical board is it can allow or deny the termination of pregnancy beyond 24 weeks of gestation. It takes into consideration the safety of the woman at that gestation age, whether the MTP can be done or not. And it also takes into consideration whether the fetal anomaly is lethal and incompatible with life, or if the child when born would suffer from such medical or mental or physical abnormalities to be seriously handicapped. So it takes into consideration these 2 points, and it may allow or deny the termination of pregnancy beyond 24 weeks of gestation. And it can as well co-opt other specialists in the board, like a fetal medicine specialist or cardiologist, or in case of cardiac anomalies. And it may also ask for additional investigations if required to decide for the termination of pregnancy. FOXI with ministry guidance and WHO support as a part of respectful abortion care can operationalize and host medical board information on website. And this is going to take place in coming few months. So what are the functions of the medical board? The medical board examines the woman and her reports, and it provides the opinion on the Form D with regard to the termination of pregnancy, and the medical board has to opine within 3 days of receiving the request from the abortion seeker. And it ensures the termination of pregnancy in a safety conditions, and along with the appropriate counseling within 5 days of the receipt of request from the abortion seeker. So 3 days, the board has to opine and has to see that the process is completed within the 5 days. And the FOXI has an important role to play in ensuring there are functional medical boards at every state, as it is stated in MTP Amendment 2021. So by the formation of the medical board, the role of the court ends, and only the medical board has to give the opinion, and there is no need for the abortion seeker to approach the court. So request all you people to do the post test and also give the valuable feedback, and let us make abortion safe, respectful, and unbiased, and as abortion is legal, and also let us make Samarth Bharat and Sampurna Bharat. Thank you. So ma'am, Shailaja ma'am, can I go ahead with second presentation, or any question and answers? Can we go ahead with question and answers?
Ma'am, is it necessary to take husband consent?
No ma'am, there is no need for the consent of the husband. Any major can as well sign, any woman who is major can sign for herself. In case of a minor, the guardian has to sign, and the guardian can be anyone who is a major, need not be a relative also. Anyone who takes the responsibility during the procedure can take the, do the signature.
Recently, one case has come for me. Their marital issues are there. The wife is 24 weeks and she is going to apply for divorce. And can I take this type of case, ma'am? 24 weeks, she is going for divorce, and husband consent is not there. She came for abortion.
Yeah, ma'am, already we have seen that the 7 groups of vulnerable women. So in that, the ongoing divorce or ongoing pregnancy during the widowship, she can as well go for medical termination of pregnancy, and if she is a major, she can sign for herself. There is no need of husband consent. Ma'am, even in the tubectomy, any procedure, there is nothing like taking the consent of husband.
So
Rules
And
have changed, yeah.
yeah, and can we give documentation like while going discharge? Can we give the summary like she came for abortion and we did abortion? Like
Uh,
earlier I used to give a plain paper because I am afraid of the legal problems. So in plain paper I used to write medicine. So can we write royally give the discharge card?
Ma'am, actually we are supposed to maintain the privacy. So nowhere we can write the name either on the IP card or the OP card. And then if she insists on the discharge summary, she is breaking the her own privacy. It is not us, we are like breaking the privacy. So if she is insisting, take a signature that she is only breaking, she is only uh, opening up or to say, or she doesn't want to maintain the privacy, and then we can as well give her. And it is like very important, ma'am, all the documents should be under lock and key. All the admission, register, consent form and the RMP opinion. And form 2 we are supposed to send to the government, that is the DMHO or the district authorities. Rest all should be under key and lock, and only the admission number has to be on the IP number, IP file, OP file.
Suppose if the patient is a rape victim, then is it medical legal case and we need to give information to the police station and all?
If she is a minor according to the POCSO Act, definitely we have to give. In case of the major also we need to give, but by the time she comes with the pregnancy, it is almost like a time being which in between she has to report to the police station. Like she has to approach before she becomes pregnant, no? So that is that is in the due course, and whenever if she is a rape survivor and then she has been tested in the hospital, usually they give the emergency contraception cover for the sexually transmitted diseases, and all that will be over.
If she has not reported before and now she has come to us and confides in us that there has been an assault or it is the pregnancy is because of rape, and it is within our this thing to report to the police.
Yeah, then we have to report. Then we have
Unless she does not want it, even then also, I mean, POCSO definitely we have to report, irrespective of their wishes and will.
Then we have to report.
Under 18, we have to report.
Usually, like if she has already approached, they must have given the emergency contraception and all this will take place. Otherwise, if she comes saying that
rape survivor is also the vulnerable group, like divorcee or widow. So 20 to 24 weeks. That extension liberalization government has given.
So shall I go ahead with the second presentation, Dr. Shailja?
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you. Yeah, please go ahead, ma'am.
One second.
Hi, good afternoon, everyone. Sushila, good to see you. Shailaja, Manasa, and Kiranmai, good to see everyone.
Good afternoon, sir. Dr. Vijay Lakshmi, Dr. Shailaja, Dr. Manasa.
Yeah, great. Good to see everyone. And each one of you continue doing very well. A huge congratulations to the society.
Thank you, sir.
Please carry on. Yeah. Sushila,
Ajay sir, thank you. So going on to the second module, it is regarding the existing guidelines of medical method and the surgical method of abortion, and also the pre-abortion assessment. So WHO has given the guidelines on safe abortion, and many handbooks have been released, like on safe clinical practice handbook for safe abortion.
Madam, you haven't shared your presentation.
Madam, I did so.
Acha, not visible.
It is not visible, ma'am. 1 second.
Do it again, I think.
Yeah, 1 second. 1 second. 1 second. I'll just share it once more. One second. Let's do it.
While Sushila is trying to get her, don't stress, Sushila. I'm sure you'll get to come on. Just wanted to let everybody in the group here know that the Dhira Obstetricians and Gynecologists TOT is coming up. The society has been informed about it. We require master trainers to get trained on that program. So please take the link from your society president and secretary and do join in for the TOT so that you can become part of that massive national initiative on Dhira, which is led by our president, Dr. Shanta Kumari.
Are the slides seen, Dr. Kiranmai?
No, not yet.
Not yet, ma'am.
Not yet. There's some problem, I think.
Can Shriman, I mean, is he here? I don't know. You want Shriman to share for you?
Yeah.
Or you will try once more, maybe?
Yeah, I'll just try once more, once again. So before there was... Now, Dr. Kiranmai? Dr. Kiranmai?
No, no, ma'am. No, no.
1 second, okay.
సుశీల పిన్నమ్మ నేను ఇప్పటిదా మాట్లాడినాం అనుకుంటా కమ్మ వినిపిస్తే మనం
Dr. Sridevi. Yeah.
వినిపిస్తే
Not able to see Dr. Sushila. She's
Mansa, Devasani, please do go ahead and share the bank account details of the society on email. Yeah.
Sorry, sir. Bank account details of the society.
Yeah, bank account details of the society so that Foxy can release the honorarium for the society.
Yes, sir.
For this program.
Sure, sir. I'll share, I think, by the end of the program, sir.
Sorry?
I'll share, sir.
Yeah, send it on email and it will be done.
Yes, sir. Yes, sir. Thank you.
Shriman? Shriman?
Sriman, we are having a challenge with opening the
Shriman, can you just allow me to be the...
share the PPT, second one.
No, I can share, but he has not made me the host.
Okay.
Shriman?
So now you become a co-host.
Yeah, now you're the co-host.
Is the screen seen?
Yes.
Yeah, thank you.
I mean, you just started sharing. Yeah, it is seen.
So the second module is regarding the existing guidelines, pre-abortion assessment, medical methods of abortion and surgical methods of abortion. So sorry for the hitch in between. Yeah, and WHO global guidelines have been given on safe abortions, and many practice handbooks have been released by WHO, like technical and policy guidelines, medical management of abortion, and like in a decade there have been so many books, and then which have helped us also. For the Indian guidelines have also been given regarding the adaptation of WHO safe abortion guidelines and landscape assessment of availability and quality of medical abortion. Yeah. And we know about the historic law which has come into yoke since last 6 months, And then this act has been, like MTP has been legalized in 1971, and now the amendments had made it a comprehensive care which has been mandated by the law. So the three key areas have to be, like, we should know the guidelines in the management of safe abortion. The first one is the pre-abortion care, the second is the abortion care methods, and the third is regarding the aftercare follow-up, including the contraception and counseling. So the medical history has to be taken, the physical examination has to be done, if required laboratory investigations have to be ordered, and we have to discuss regarding the contraceptive options. And while we are giving the options, we should always be careful about the duration of the pregnancy, what method we are giving them the choice. So we should definitely help them during the decision making whether we can go for a medical method or a surgical method. So the pre-abortion, as I said, we have to take the history, do a physical and a pelvic examination, order for the investigations if required, and do a counseling regarding the procedure and also regarding the contraception. So the gestational age is determined by the LMPA and also confirmed by the physical examination. We all know that uterus is a pelvic organ till 12 weeks, and midway between the umbilicus and symphysis pubis at 16 weeks of size, and 20 weeks it is up till the umbilicus. And there are few limitations, that is, the uterus is more than the size expected in case of multiple gestation, uterine fibroids, molar pregnancy, and the size is smaller in case woman is not pregnant, inaccurate menstrual dating, ectopic pregnancy. So there may be some disparity, but we have to confirm with the pelvic examination and also by the physical examination. So routine lab tests are not required, that is, they are not the prerequisites for the abortion services, but can be asked for in case we have the individual risk factors on findings of physical examination. If we need, we can ask for the investigations. In case we have a doubt about the pregnancy test can be ordered. If we suspect anemia, hemoglobin or hematocrit can be asked for. HIV testing and after counseling of the patient can be asked depending upon her sexual history. And in case of pelvic infection, we can ask for the STI screening and laboratory tests like RFT, LFT in case if the patient is suffering from any medical ailment. And regarding the RH type testing, we need to ask the woman if she's already like she knows the blood grouping and typing, that is okay. But if she doesn't know a blood grouping and typing, maybe we need to ask her, because the RH testing is so important that it would affect her future reproductive pattern. So definitely we should know the RH typing. So we may need to ask her to get a blood grouping and typing. Then ultrasound is not mandatory unless we suspect ectopic pregnancy or a missed abortion. There is no compulsion or ultrasound is mandatory. So we should ask the patient. Why she has come for termination, that is the reason for termination. We should inform that the early abortion is safe and also it is safe with the trained provider, and what are the available methods have to be discussed regarding the abortion. The risks and warning signs associated with the abortion methods have to be told to her. And without the contraception, she can become pregnant within 14 days has to be informed to her. And resumption of her normal activities, including the sexual intercourse, have to be discussed. And any other follow-up care has to be talked to her. And everything has to be documented. It should be an informed written consent. Decision to accept post-abortion contraception is can be left to her. And if she denies contraception, we cannot deny the abortion services. We have to go ahead with the abortion services. And Government of India recommendation is the medical method of abortion is only up to 9 weeks. Up to 7 weeks, the combined regimen, what we include, that is a mifepristone 200 milligrams orally, and then misoprostol 24 to 48 hours has to be given either sublingually, buccally, vaginally, or orally. This is up to 7 weeks. From 7 to 9 weeks, it is the same regimen, except that we cannot give misoprostol orally. It can be either sublingual, buccal, or vaginal. So in the global recommendation, less than 12 weeks, we can go ahead with the mifepristone or misoprostol only regimen or vacuum aspiration. If it is more than 12 weeks, according to global recommendations, it is mifepristone and misoprostol or misoprostol only regime or dilatation of evacuation, and we should not be followed by a sharp curettage. So never we should go ahead with a sharp curettage. So apart from the medical methods, we also have the surgical methods of abortion. And mifepristone is an anti-progesterone. It inhibits the progesterone, interferes with the continuation of pregnancy, causes necrosis of the decidua. And when misoprostol is inserted, it causes uterine contractions and also the cervical softening and expulsions of products of conception. So they are complementary to each other for the process of abortion. And day one is we give the mifepristone orally 200 milligrams. In case of she's RH negative women, anti-D 550 micrograms can be given, or if it is not available, we can go ahead with the full dose of 300 micrograms. And day 3 is mifepristone, this is misoprostol administration. Up to 7 weeks, 400 micrograms of misoprostol, 2 tablets can be given sublingual, buccal, vaginal or oral. From 7 to 9 weeks, it is only sublingual, buccal, vaginal, no oral administration. In addition, we can also give her analgesics, antiemetics in case of vomitings, and we have to talk about the contraception. And follow-up day is on day 15. We have to confirm the completion of the procedure and talk to her regarding the contraception again. And maybe if she is willing, we can start her the contraceptives. So the oral route, the pills are swallowed. In the buccal route, the pills are placed between the buccal mucosa and the gums and swallowed after 30 minutes. And in case of sublingual, it has to be, the pills have to be placed under the tongue and swallowed after 30 minutes. And in case of the vaginal insertion, the tablets have to be placed in the deepest portion of the vagina, and the woman is instructed lie down for the next 30 minutes. So the side effects are vomitings, fever, chills, diarrhea. This is more in case of sublingual route and the oral route, because it is like immediate plasma concentration levels are reached with the oral route and sublingual. And compared to oral and sublingual, the buccal and vaginal have less side effects. So always it is like when it is inverted V, whenever we give a misoprostol, either sublingual or oral, it is like inverted V. It shoots up immediately and comes down. But in the buccal and vaginal, it is an inverted C. It is a sustained release action of misoprostol. So this is where the tablets are placed. This is between the buccal mucosa and the gums. And this is sublingual, where it is placed under the tongue and swallowed after 30 minutes. So according to the WHO regime, less than 12 weeks, 200 milligrams of mifepristone given orally and 800 micrograms are given either buccal, vaginal or sublingual, and the misoprostol only regime where 800 micrograms is given either buccal, vaginal or sublingual. And vaginal bleeding for 2 weeks is quite normal, but bleeding can occur up to 45 days, but this is in very few cases. So the services of medical method of abortion, that is the tablets like mifepristone, misoprostol can be given at the primary level, but in case of any complications, or we have to refer it to the higher center. So the additional services like counseling, testing for sexually transmitted diseases, abuse support services, psychological or social services, and other specialist services can be given when the patient comes from medical method of abortion. We can as well give her the iron tablets in case of anemia and pain medication if she is suffering from pain, and definitely we do have to support her emotionally. So routine follow-up is not necessary unless it is been complicated medical abortion. And in case of only that is misoprostol regime alone, like we are giving only misoprostol, then she has to come for a follow-up visit. But in case we need to counsel her regarding contraception and address her medical concerns, or if she has to be supported emotionally, maybe we can call her 7 to 14 days after the procedure. So assess the, in the follow-up care, assess the woman recovery and ask her any signs and symptoms of ongoing pregnancy. Review her medical records and documents. Ask her about the experience during the procedure, and Focus on the physical examination regarding if she complains she has any particular complaint, focus on the physical examination and perform the physical examination, and assess the woman's fertility goals and need for contraceptive services if not provided earlier. So if we have not discussed regarding the contraception, this is the time where we have to discuss her on the day 15. And in summary, for the medical method of abortion, on day 1 physical pelvic examination, confirm the eligibility whether she's 7 weeks or up till 9 weeks. Give her the tablet mifepristone 200 milligrams orally, and if she is RH negative woman, anti-D either 500 or 50 or 300 in a full dose can be given if 50 is not available. And tell the woman to return for the misoprostol administration after 2 days, and give her the contact address and phone number where she has to go in case of an emergency, and ask her to record her experience on the MMA card. 3% of the women they expel with the mifepristone only, but we have to continue with the misoprostol schedule. This is to complete the abortion. On day 3, misoprostol is given. Observe her 4 hours in the hospital, either in the casualty or emergency room. In case of the pain, ibuprofen 400 milligrams can be given, and contraceptive options have to be discussed. And tell the woman that the bleeding would take place from for 8 to 13 days, and possible side effects of nausea, vomiting, diarrhea, headache, fever, dizziness have to be explained to her, and ask her to report in case of excessive bleeding or in case of pain, abdomen or fever, and ask her to come back if there is no bleeding also. That is the pregnancy, it indicates that the pregnancy is continuing. So she has to return if there is no bleeding after the misoprostol has been given, so that we can go ahead with the additional dose of misoprostol. And 75% of the women abort within 4 to 6 hours after the misoprostol administration. So on the follow-up day, that is day 15, pelvic examination has to be done in case we feel that the abortion is not complete, and the contraceptive options of hormonal method, condoms, IUCD can be given to her, and she has to come back for after the next menstrual cycle for sterilization. And tell the woman regarding the return of fertility within 14 days, and report back if there are no periods within 6 weeks of completion of the abortion process. If she misses a period, she has to come back again, and ultrasound is only performed in case we have any doubt that the process is not complete. Regarding the side effects, don't be judgmental about the pain, give her the verbal support, and then all this has to be taken care that it is in a respectful manner. Adequate counseling has to be given regarding pain, and we need to talk to the support person regarding this pain and the other side effects also. Ibuprofen 400 milligrams can be given to the women. In case of the persistent pain, we have to be careful, and we need to exclude ectopic pregnancy or incomplete abortion or infection. Nausea, vomiting, diarrhea are self-limiting, so reassure her. And infection, like if she comes with a foul smelling discharge, we need to examine her and give her broad spectrum antibiotic. In case of failure of medical method of abortion, we may repeat the dose of medical method of abortion, or we can as well offer her vacuum aspiration. In case of incomplete abortion, we have to repeat, either we can go for a repeat dose of misoprostol, or we can go for vacuum aspiration, and observe unless heavy bleeding, the bleeding resolves and the uterus returns to the normal, which indicates the abortion is complete. So if the abortion is not complete, we may need to go for a repeat dose or go for a vacuum aspiration. Suppose if the patient comes with an excessive bleeding. So what is excessive bleeding? Bleeding more than her menstrual cycle, or soaking 2 pads in 1 hour for 2 consecutive hours is excessive bleeding. So ask her to come back if she has excessive bleeding to the casualty. By the time she comes, if the bleeding decreases, we can watch her, keep her under observation, and ask her to go home after 4 to 6 hours. And we need to watch the vital signs, do a PV examination, and we can do a digital examination if the products of conception are felt in the cervical canal. And if the patient becomes stable and the bleeding reduces, we can keep her in the casualty for 4 to 6 hours and discharge her once the bleeding stops and the vitals are stable. But if still the bleeding continues, ultrasound has to be done, see if the products of conception are remaining. So if the only minimal bits are remaining, then we can wait and watch if the woman is stable. But if the woman is not stable, we need to go for vacuum aspiration. If the woman is stable, we can give her a dose of 600 micrograms of misoprostol either orally or sublingually and keep her under observation. And if pregnancy is continuing, we have to go for vacuum aspiration. And recording has to be done, and reporting of the medical method of abortion has to be done, because this comes under the purview of MTP Act. And similar documentation has to be done as the surgical method of abortion. It is mandatory to fill the Form C, which is a consent form, where the woman is going to sign on the form. Form 1, the RMP, either one. In the case of Form 1, or Form E, where it is from between 20 to 24 weeks, where two RMPs have to give their opinion. And Form 2 is monthly reporting form, which we are supposed to send to the government authorities, that is the district authorities or the DMHO. And Form 3 is the admission register for case records. And we have to keep this under lock and key along with the consent form and the Form 1, that is the RMP opinion form. So coming to the surgical method. So surgical method is the vacuum aspiration and is a recommended technique of surgical abortion for pregnancies up to 12 weeks. And WHO recommends manual vacuum aspiration as the safest method, and the procedure should never be followed with a sharp curettage. So this is a manual vacuum aspirator, and this works on the principle of generating vacuum and aspiration of the products of conception. And this can be used in the low setting where the electricity is a problem, low income resource setting. And the aspirator is attached to a cannula which is 4 to 12 millimeters in diameter. And the use of the cannula corresponds to the weeks of gestation. That is, 8 mm cannula is used for 8 weeks and 10 mm cannula for 10 weeks of gestation. So this is an electric pump, which we commonly use during the cesareans for aspiration of amniotic fluid also, and also for the assisted vaginal delivery with vacuum. And it is an electric pump. It generates vacuum and works on the same principle of manual vacuum aspiration. And cervical priming is an important part. That is, we can do the cervical priming. This prevents mainly the rupture of the scar in case of a scarred uterus, and also helps to easily dilate the cervix. It makes the cervix easily dilatable. So the pain, the patient also complains of less crampy pain. So the recommended methods of the cervical preparation before surgical abortion the first trimester are oral mifepristone, given 24 to 48 hours in a dose of 200 micrograms, or misoprostol can be given a dose of 200 milligrams. Misoprostol is given in a dose of 400 micrograms either sublingually or vaginally 2 to 3 hours prior to the procedure, and laminaria tents can also be placed intracervically 6 to 24 hours prior to the procedure. So pain management is also important. It reduces the pain and anxiety and makes the woman comfortable. It has two components, the non-pharmacological component or the pharmacological component. We can follow either one of them or both. So the non-pharmacological pain management is by giving psychological support and explaining each step to the woman in advance so that the procedure is completed gently and smoothly. And we can encourage the woman to relax and breathe deeply during the pain. And regarding the pharmacological pain management, we can give her the anxiolytics like diazepam, 10 milligrams orally 1 hour prior to the procedure, or 2 to 5 milligrams IV 20 minutes prior to the procedure. If she's too anxious, we can as well go for a short general anesthesia. And cervical dilatation can be done with the paracervical block. 10 ml or 1% xylocan can be injected. And analgesics can also be given 400 to 800 milligrams 1 hour prior to the procedure. This decreases the uterine cramping. So steps of MVA. So the instrument, that is a manual vacuum aspirator, has to be prepared. That is, the wall button has to be closed. Vacuum is created by pulling the plunger back, and the pain management has to be done. We can give her prior ibuprofen of 400 to 600 milligrams, ask the patient to empty the bladder, cleanses cervix, and administer a paracervical block by injecting 10 ml of 1% xylocan in the other sites, that is except the 3 and 6 position. And we need to dilate the cervix, and it is easy if we have already primed with this either misoprostol or mifepristone. And we need to insert the cannula. Withdraw the cannula by 1 to 2 centimeters from the fundus to prevent perforation, and rotate the cannula. Release the vacuum button of the aspirator, and the products of conception will be seen coming into the cannula, and we can rotate it by 360 degrees. How do we know the products of conception have come out and the uterus is empty? This is by red or pink foam without tissue passing through the cannula, gritty sensation over the surface of the uterus, cervix gripping over the cannula, and uterus contracting around the cannula, and there is also increased uterine cramping. So once we feel that the uterus is empty, we need to take out the cannula, put all the products of conception, inspect the tissue in the petri dish under the light, and if we feel that the procedure is complete, there are no other complication, we can as well go ahead with IUCD insertion or a sterilization procedure. And the instruments have to be disinfected. It has to be washed, put in 0.5% chlorine solution for disinfection. This helps to remove the remaining tissue which is stuck to the instrument. And post-procedure care, monitor her for any complications and provide management as needed. She may leave the facility when she is stable and the discharge criteria are met. Ensure that the woman has all the necessary information and medication prior to leaving the facility. So we have to tell her in case what are all the warning signs, and also where she has to report in case she has any complications. Document everything, what treatment has been done, and then what is the procedure, what treatment has been given to her, and including any adverse events that has taken place during the procedure, both in the register that we have and also in the client's record. So the aftercare management of the abortion complications we have to take care of the complications, provision of the contraceptive information and offer her contraception counseling and methods, assess the sexual and reproductive health, and then counsel them regarding their reproductive health also, that the repeated abortions are not good for their health. And follow-up is, no routine follow-up is needed unless it is a meso-alone regime. So in summary, India has made historic progress in improving the access to abortion, safe abortion, and not much has changed in the technology update in the last decade. As provider, it is up to us to ensure safety and quality, and we have to stick to the amended law rules. And along with the safety, we also need to focus on the respectful abortion services. We have to be unbiased. We have to respect the women. And every client, either a private client or a public client, it is an opportunity to educate them regarding the contraception, regarding the counseling. And over and above, we should fill all the forms that we are supposed to do so. And then the form 2 has to be sent to the government. Other things we have to keep under lock and key. And also we should follow the gestational limit in case of the normal women, and also we should know who are all the vulnerable women and till what weeks we can give the abortion services. And also we have to follow the safety precautions, and unbiased respectful abortion care has to be given to her. So I request you all to finish the post-test after the session and also give the feedback. And let us all make the abortion more safer, more respectful. And thank you all for the patient listening. Thank you, Dr. Shailja.
Ma'am, thank you, ma'am. Thank you, Sushila, ma'am, for such an elaborate and detailed abortion. We have a lot of doubts. You cleared most of our doubts. What is the minimum hemoglobin level to take up the abortion case, ma'am?
10 grams would be minimum. But one thing, ma'am, like if she is anemic also, we cannot deny her abortion. We have to do the needful, that we have to improve the blood levels and go ahead with the abortion immediately. We cannot postpone the procedure.
We have to give blood transfusion and then go for an abortion.
Anemic, we can.
Then uh, medical abortion, is it mandatory to admit the patient, madam?
Yeah, like day three, we have to keep the patient for 4 to 6 hours after the insertion of the misoprostol. We can keep her either in the casualty or the emergency room, and then we can send her once she expels most of the products.
And Karimnagar is a place where nobody wants to stay in hospital. They just want to walk in and take the tablets and go away. That's all. This is what happens in Karimnagar. They just walk in like as if they have come for a beauty parlor. They come and
Ma'am,
yes, ma'am.
it is if it is nearby, maybe we can allow, but in all the slides and all, what we have shown is that they are supposed to be there for 4 to 6 hours. That is always safe.
Hmm.
Dr.
Okay, ma'am.
What would you say, Kiran?
Yeah, that 4 to 6 hours on day 3 is really very important, I feel, because that is when the maximum passage of products and symptoms and bleeding happens. Once we counsel, some of them do agree and stay back, but as you said, once we say admission, it becomes a little more tricky. But we can counsel, and it depends upon the proximity to the hospital and any attendant with them, so that they can come immediately, and especially telling them about the size of the clots and number of clots, and the 2 hours each hour, losing that lemon-sized clots, and that symptoms of giddiness and all. That also is very, very important. Otherwise, they take it too lightly. So it is just because it is medical, it doesn't mean that we have to impress upon them that only the method, medical and surgical, the terminology is different. The process of abortion is equally, same kind of complications and same kind of, it is not simple. I mean, even medical, and also the possibility of failure and incomplete abortion also has to be stressed upon very clearly in the beginning, that they may need the surgical evacuation and all.
So, Dr. Shailaja, always we give.
Sushila ma'am, post-cesarean, 2 previous sections and all, it is really important that they stay for this 4 to 6 hours on day 3. At
And
least you
also,
can do that. I mean, simple cases
Yeah.
without scars, maybe you can send home with proper counseling, and with post-cesarean, you can ask them to
Yeah.
stay back.
The day one, when we give the MMA card to them, ma'am, they usually go through it, and usually it's not really a problem to stay for that 4 to 6 hours, because it is definitely on that, and then they know all the warning signs are all written on that. So they usually, they usually accept to stay at the hospital for those 4 to 6 hours.
Ma'am, earlier it was like an abortion. It is something which we are not supposed to do and which is of disrespectful. But the term has changed to respectful
Yes.
abortion care. This is so nice to hear. And
Recently,
in fact,
FICO has released a important policy statement as decriminalization of abortion. I mean, now it is more liberal. We can't judge them, label them, and say that how many abortions or
Yeah.
how many children, nothing. And I remember in GMH, maybe a decade or 2 back, we always used to club MTP with one or other method of family planning, at least property or sterilization. So now you can no longer, you can counsel, you can tell them the importance of contraception, etc. But you cannot deny, and you cannot speak disrespectfully.
yeah.
So now abortion is said to be healthcare by WHO.
Yes, you cannot deny the access. By denying the access, you are not helping. So by denying the access, you are making the unsafe abortions more.
The moment unmarried pregnant lady comes, our staff, how they look and they express
Yes,
their
ma'am, very
views,
important
and
aspect of it.
this is the social taboo we have.
I think my presentation will deal with these issues. And unmarried, I think Dr. Sushila has told, in the vulnerable group. So again, the government has removed that clause of married, unmarried also. It is only the age which matters. and husband sign. All these have been removed totally. So it's the human, it's the right of the woman to seek care, you know.
Thank you very much, ma'am, for elaborate explanation about medical termination of pregnancy. And one more doubt, ma'am. Ultrasound is not mandatory, ani annaru, madam. But
Yeah,
incomplete
Prati
abortion.
session lo we are having this discussion, ma'am. But ultrasound mandatory kaadu. Kani, if you have the access, if the patient is willing, and if you think you will help her more by using ultrasound, you are free to use ultrasound. But the meaning of this not mandatory is like it's a remote place. I am practicing there. I don't have an ultrasound, and she comes for abortion early trimester. It means that just because I don't have an ultrasound, I cannot go for this medical method of abortion or early trimester, early pregnancy abortion. So lack of ultrasound should not deny the woman the right to seek abortion care. That is what government wanted to remove that access ఏవేవైతే అడ్డంగా ఉన్నాయో అవి it has right to remove. It said it's not mandatory. It didn't say you should not do.
So because abortion can be performed in low setting also.
So
nowadays
we do not have ultrasounds in low setting. So at low setting also it can be given.
Because
So
ultrasound access in maybe PHCs or rural settings is it may not be possible almost in many places. And what happens is just because ultrasound is not there, they'll be sent from place to place, and meanwhile she'll be going from place to place, and her gestational age increases and other things also. So that is what the government wanted to remove.
Post-abortal also, ultrasound is mandatory, what I feel, ma'am, because how do we know that total uterus has been evacuated or some products of conception?
More than ultrasound, it is the history which is very important. History is very important. That is passage of products, and then slowly the reduction of the bleeding and your clinical examination. Again, here it is, the word is mandatory. Word is mandatory.
We have a doubt and we have a provision, we can as well go with the ultrasound. But if it is not mandatory, in sense, it is not like we cannot deny her from the service. We can go with the vaginal.
For example, in a PHC, no resource setting, we have given her medical method. You reasonably are certain that she has passed all her products, the bleeding has reduced, and uterus has returned to normal size. Now you are reasonably reassured, and then you tell the woman maybe the process is complete. So, but still you may have to counsel her regarding if any, again passage of clots or irregular bleeding, anything, to come back early. That is it. I mean, ultrasound, again, the role of ultrasound is they have put, maybe we can say, optional, not compulsory.
Ma'am, for painkiller, tramadol, paracetamol, antispasmodic, can we use?
Yeah, actually the module says NSAIDs, no, Dr. Sushila?
Yes, NSAIDs.
We say ibuprofen. There was a discussion on that also. Yeah, tramadol and paracetamol can be used.
That's what in the previous, like in some of the RAC talks only, they have told that except for the ibuprofen, all the other drugs, they decrease the expulsion. So better is go with the ibuprofen.
Okay.
So other drugs, they can hamper the expulsion.
This is extensively, discussed and done by the people. The core group people are from Government of India module, WHO and AIMS from All India Institute of Medical Sciences. So who prepared this RAC module? So everything has been discussed, and it must have gone through so many.
Ibuprofen is available everywhere, no ma'am. So we can go with it rather than.
They have done kind of this module to not to compromise safety, but at the same time liberalize it, improve the access, and added the respectful component to it, and counseling.
Ma'am, usually I give orally only, mifepristone and misoprostol. Both orally I give, but nothing, no abnormality detected till now. So Can I go with that or mandatory vaginal or buccal?
Till 7 weeks, oral is okay, ma'am, but 7 to 9 weeks, we need to go either for the sublingual, buccal, or vaginal, because the number of incomplete abortions are more. So the success rate decreases with the oral. So better is to go with the other routes rather than with the oral between 7 to 9 weeks. Up to 7 weeks, you can go with all the 4 routes, any of them.
Thank you, ma'am. Thank you, Sushila, ma'am.
Thank you so much.
I invite Dr. M. Vijayalakshmi as a chairperson for Dr. Kiranmai Devineni for the next topic. That is WHO Saver Toolkit Safe Abortion Values, Evidence and Rights Towards Respectful, Bias-Free Services. Thank you, ma'am. Thank you so much.
Good evening. Good evening, respected delegates.
Good evening.
Good
Good evening.
It's a huge honor to be present in this training program, Respectful Abortion Care, a joint FOXI and WHO initiative. And first and foremost, I would like to thank our own president, Dr. Shanta Kumari, for coming out with this new initiative. And in my 30 years of my practice, I have never seen this type of training given to a professional. So, as you all know, 30,000 abortions are occurring per year, but mostly 97% are from developing countries, and there is 8 to 11% of maternal mortality rate also. So the word respectful is a very novel term, as Shailja said, because I have seen many patients coming to me with unwanted pregnant women are treated very badly in the society, leave alone the family and all. They are abused, they are criminalized, they are stigmatized. But with the new MTP Amendment Act, the rules are a little relaxed, and now we can perform abortion, safe abortion procedures in a peaceful manner. Now, Dr. Kiranmai Devineni, a very dynamic Foxian. It is not exaggerated if I say that she is right hand to, and she's coming to our biodata. She is professor in OBGYN GMH Vanaparthi, Kaloji University of Health Sciences, and she is coordinator, national core member, TOT, and faculty DIRA, a Foxy-led initiative to combat violence. And she is workshops coordinator, Foxy 2021 to 2022. She's trainer of trainers, UNICEF, gender-based violence.
That would be enough, ma'am. Thank you. I'll go ahead with. Thank you. And
no. I have to say one word.
No, I'm one of
She's recipient of MS Signature Award.
One of your own. Please. Thank you. Thank you.
Yes.
I'll share my.
Now I invite Dr. Kiranmai for a presentation on WHO Saver Toolkit, and now it's on.
Thank you, ma'am. Thank you.
Safe abortion values, evidence and rights towards respectful bias-free services.
Shriman, you have to enable me to share my screen.
Madam, I made you host, madam.
I don't know. It's showing. Yeah, thank you. Oh, 1 second. Let me share again. I have to share the sound also. Yeah. So we come after the important ones. Yeah. after the important the amendments of the MTP Act, and the next the technique and technology of it, the most important, equally important part of it, that is respectful abortion care. This mostly deals with the SAVOR module of WHO, which is safe abortion values, evidence, rights, and respect. So, this is a joint FOXI and WHO initiative, and I agree with Dr. Vijay Lakshmi that this is almost the first time that we are seeing such innovative partnerships and complete use of online platform, and and the participation. We are sitting at different places in India and we are interacting with each other, and such beautiful modules prepared by experts. So a pleasure to be here with you all today. So this module basically aims to define what is respectful abortion care by WHO standards, and highlights how our norms and our stigma affect the services, and provides the resources for this WHO SAVOR module for the respectful abortion care. So the momentum has been created. You have seen how the law has changed and how it has changed, and this dissemination needs the association and partnership and the OB/GYN provider support. Who else but FOXI? We are the largest provider base for the abortion care, and because online training is possible due to COVID, and now we are able to make this respectful care module, abortion care module, to reach all the providers. And the MMA uptake has increased, making the early abortion safe, and the patient safety, respect, and quality matters more than ever, and we all have an important role to play in this. So what is respectful abortion care? According to WHO, it refers to care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continued support during and after all types of abortion. So in simpler terms, respectful care means if you are a provider, you treat with respect, and if you are a patient, you are treated with respect, dignity, empathy, and compassion, irrespective of your race, your ethnicity, gender, socioeconomic status, or most importantly, reproductive history. The number of pregnancies, the marital status, the miscarriages, number of abortions, this is not going to affect the care that you are going to give to the patient. So as a patient, if you ever feel that something isn't right, you have to speak up. And as health professional, it is our duty to listen and support. That is, communication is the key. So let's see what are norms and stigma. This is this beautiful small video which very clearly shows how the norms and stigma are affect our services to the patients, and also how they are different from the laws, and how we have to very clearly differentiate between the between all these things.
Social norms are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors, like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adult sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and women's health will never refer to abortion habitual and understand that norms in this exercise how norms
Shriman,
Yes, ma'am.
Shriman,
Madam. Yes, ma'am.
I think that's some problem from Kiranmai's end.
Yes, ma'am. I'm calling madam.
Yeah. Dr. Shailaja, any questions? I think we can go ahead with them. Meanwhile, Dr.
Madam, can I ask you a question, madam?
Yeah, yeah, sure.
Madam, Sushila, madam.
Yeah.
Madam, if a couple comes,
Yeah.
at 18 to 20 weeks gestation, and she's having one girl child previously, and now they somehow came to know the sex of the baby. Now they want termination, but they will say like it is a failure of contraception, or she conceived in lactational amenorrhea, so we don't know. So in that ground, what should we do, madam?
So till now, I think we have done in the same way, like saying like it is injurious to her mental health, and failure of contraception was one more reason. So on our part, it is the social responsibility that we need to counsel her regarding that. Like after early abortions are safe and late abortions are always a problem. And then counsel her regarding that. And if she has come for a girl, because it's a girl child, tell her that again she may not have a boy child next time. So try to counsel her, do your part of it, and then if she still insists on that, go ahead and do it. We cannot just say you cannot, otherwise they go to a quack and then they get an unsafe abortion done. If
Madam, most of the times the girl is innocent. The husband or family members are forcing her to undergo abortion.
But she has to sign on the consent form.
Yes, ma'am.
She signs, that is okay. We can go ahead. Nothing like we cannot interfere in between them. If she is ready to sign on the consent form, that is Form C, we can go ahead. Legally, we can go ahead with the abortion.
Thank you.
And then another point is, I would like to say is the consent form is different, and the form for the surgical or medical method consent form is different. So always it is better to get the couple consent on that form, and then on consent form C, we can get the signature of the woman herself. So that is always better. Sometimes we have these problems that husband comes after like a year or so saying that he didn't want it, but the wife came for the abortion. So at that time, it is always better that we have another form like medical method of MTP form, and then surgical method, because we have that vacuum aspiration. We have all these forms in the Foxy website, consent forms website. So we can download and then translate in Telugu and then in the native language, and better we get the signature of both the couple.
Madam, when the husband doesn't stay in town or he's away in some abroad, is that telephone intimation that works, madam?
No. In case of a major, only she can give the consent. No other person can give the consent. If she is a minor, then any guardian, maybe a relative, maybe mother-in-law, father-in-law, a friend who is a major. That's it. It is not like that. Somebody who's related has to give, husband or in-laws.
Okay.
So, and in case if she comes with heavy bleeding, the superintendent of the hospital can sign for her. Yes, if it's a minor.
Okay.
That is humanitarian grounds.
Okay.
So on one side, the doctors are victimized for female feticide, and on the other side, these rules are relaxed. It's a double-edged sword.
Definitely a double-edged sword, and we have to be very careful while we are preserving all the forms, filling all the forms. So we need to send all those forms. PC, PNDT Act forms have to be here. It is online for us in Vijayawada. We send every day. By the end of like 5 o'clock or so, we are supposed to send all the day forms. And then these forms every month we send them. So once we fill the forms properly and then send them, our work is over, to say. And the only thing is we have to keep it under lock and key.
So,
and unless a person from the government authority, he comes and shows everything, we need not open. And the more difficult part is regarding the non-disclosure of the name. So usually in all the hospitals, there is a registration counter where everything is done, and the patient comes inside the OP room and tells that she wants abortion. Then we have to edit it, get the things they have to be get edited. So we cannot just keep as it is. So we need to like have a setting for editing also in the computer. So we need to do that. And then again, even though if she is married, she comes for 20 weeks abortion also, like for congenital anomalies, we cannot just keep quiet and write the name of the woman. We need to write just the admission number, and then it is like same rules for anybody, married, unmarried, any gestational age.
Dr. Sushila, sorry.
Yeah, that's you can.
I lost the connection and I was trying to. Shriman?
Madam.
I'll switch off my video.
Okay,
Yeah.
ma'am.
Yeah. I'll share again, Shriman.
Okay, madam.
Yes. Sorry about that. Shriman, you have to enable me, I think.
I made you co-host, madam. No.
Okay. Yeah. Is it visible?
Yes, ma'am, but not
Yeah.
full screen. It's still in
Yeah.
slideshow.
Full screen.
Okay.
Yeah.
Yes. I
Yeah.
think we have done with this norms and stigma.
We have done. Yeah.
Yeah. So basically, it very clearly, actually, it will be surprising to see that despite our, awareness, education, and knowledge, many of us cannot escape from this concept of, stigma and certain belief systems. So, but it is important that we keep these norms and stigma separate from the knowledge of law, and we have to unlearn this and learn new things. That is how not to be not cause stigma, and how not to be non-judgmental, etc. So these are the categories of disrespect and abuse which result because of the stigma and norms. So what are they? As Dr. Vijayalakshmi and others were telling, the way healthcare providers and different levels of staff look at women who come with pregnancy, especially unmarried women, widows, or rape survivors, etc. And this disrespect can involve as much as physical abuse and intimidating physically, and then verbal abuse like shouting, screaming, humiliating, and then sometimes sexual abuse also takes place because of the vulnerability of such women. And then stigma and different types of stigma and discrimination, and failure to meet professional standards of care. We might not be able to meet the required standards of care because we suffer from the stigma and norms, and that leads to poor rapport between women and the providers, and the health system conditions and constraints because of overcrowding, etc. So, and lack of infrastructure. But we have to realize that women have these following rights: that is freedom from harm and ill treatment, right to information, protective laws, that is MTP and POXO, and informed consent and refusal. They have the right to refuse. They have the right to have complete information before they give consent, and also to refuse. And they also are they need respect for the choices and preferences, whatever they are, and also dignity and quality of care, irrespective of their choices. And also right to timely health care. We cannot deny abortion for trivial reasons or for because of our moral obligations. And also to the highest attainable level of health, liberty, autonomy, self-determination, and freedom for coercion. These are all the rights of women. So what are the domains of respectful abortion care? The 12 domains have been described. Again, I'll repeat them. Being free from harm and mistreatment, maintaining privacy and confidentiality. Again, in the first and second modules, very clearly it has been mentioned how we have to protect the confidentiality of the woman, and preserving women's dignity, respecting their choices, engaging with effective communication soft skills. I think the next module will cover this. Providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care. Equitable in the sense we have to have whatever resources we have, we have to give a fair and unbiased division of this abortion care, whatever resources we have, availability of competent and also motivated providers, provision of contraception advice and commodity security, continuity of care and counseling. Then time to strengthen implementation. Again, why it is important? Because the law has changed, as you all know. Up to 20 weeks, it is one provider. So there is more onus on this single provider to provide respect and to educate and also reduce sex-selective abortion. So instead of 2 RMPs, it is 1 RMP with more responsibility in the realms of counseling, contraception, referral, and compassionate care. So the onus is more. And then in the 20 to 24 weeks, as Dr. Shailaja elaborately gave so many examples for discussion earlier on, in this segment, that is vulnerable women, especially young people, survivors, unmarried women, and then widows. So in the all women category, up to 20 weeks of gestation. In the special categories, that is rape less than 18 years and others, it is 20 to 24 weeks of gestation. This has been extended to cater to this vulnerable group of women so that they do not fall out of the law. So again, here comes the need for sensitivity and judgment-free timely services for this section of the women. And as you all know, in case of birth defects, there is no gestational limit and board is needed. And again, prioritize confidentiality and safety, very important. And we have to be mindful of all the socio-cultural aspects. So this is another long video. I'll skip this video in between. Actually, it tells us about what words we have to avoid. Like we have to avoid words like parent, mother, father, before they become actual parents. And we have to avoid language like feticide, etc. It is better to say sex selective abortion if it is a female involved, female baby. And it is also not right to say child. It is better to say or fetus or unborn child, or it is wrong to say you can keep this child, or get rid of this pregnancy, and all such things. And then what are the correct words to use and what are the wrong words to use? I'll just play it and play it little fast, skipping in between.
Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word of the country. The barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs, or Registered Medical Products of Conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix "side" denotes killing, which is not appropriate when describing abortion. When referring to sex-selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision, and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe who are not registered or trying to get pregnant. An unplanned or unintended pregnancy is illegal. Provider and place need to be safe, trained, and certified.
So that is basically the language that we have to use and we should not use, and also the differences between illegal abortion and unsafe abortion, legal abortion and safe abortion. So a safe abortion may be still illegal, and then illegal abortion may be safe. So safety, legal is as per law, safety is as per, the place, the person, and everything as per the required norms. So WHO training for safe abortion values, evidence, and right. This is a SAVER toolkit. So just we'll go through this also.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module based training for doctors, nurses, health providers, program managers, and really anyone to assess our values,
address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Saver Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer, or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So we all are technically very, very skillful, and everybody knows the guidelines, protocols, but this module especially adds the respect, dignity to the quality. So that is the whole thing about this. And I did check the Saver module. You also can check on Google. And you can explore the modules, each one of them. And these games are also very interesting. So it just tests our norms, stigma, and also gives us evidence-based articles and research tools, how our norms and belief systems are, they do not have evidence. So these two are examples of the games. One is Cross the Line and Personal Compass. You can take a screenshot of this, or Shriman can put the links of this in the chat box. So these are the games from the WHO Saver module. So to come to the end, from 1970s, the only aim was to reduce the unsafe abortions. To 2000s, we moved to the safe abortion care, and now in 2020s, we have added the respectful abortion component. So there are 3 recap questions. I ask all of you to put your answers in the chat box, just to remind and revise what we have learned till now. 3 case scenarios. So just put your answers in the chat box. According to the WHO, restricting access reduces the number of unsafe abortions. We have had discussion in one of our groups, and it was very interesting to know that quite a few agreed and disagreed, and there was a lot of heat generated. So just put your answers. Is it true that reducing the access reduces the number of unsafe abortions? So false, false, false. There is one true. True, false. Okay, false. Mostly false. Mostly false.
False, yeah.
I'm happy that most of the answers are false, because it is indeed false. See, as I have already told in the beginning, restricting access does not reduce the number of unsafe abortions. Actually, it increases. And as far as safety is concerned, we only should understand what is a safe abortion. That is, by definition, the methods, persons, if their criteria are met, it is safe. And if only one criteria is met, it is less safe. And if both criteria are not met, it is unsafe. So restricting access does not reduce the number of unsafe abortions. So the MTP Amendment Act, this doubt was asked already by Dr. Shailaja. It requires a minor of less than 18. No, this was not discussed, but this is again another interesting question. Many had doubts and we had a lot of discussions regarding this scenario also. If a minor comes to you for an MTP, so do you need a written consent from parents and guardians before she can undergo a termination of pregnancy? Is it true or false? So Dr. Vijayalakshmi says true. Any answers? Any more answers? True. Yeah, we are getting a lot of truths. Okay. So let's see what the answer is. It is false. So the module, the amendment now says it need not be first of all, it need not be a written consent. It need not be a parent, and also it need not be a legal guardian. Only an adult accompanying this girl, only an adult who comes as a guardian and accompanies this girl and signs. If at all, if you want a consent, not consent, as a accompanying person, only a guardian who is an adult. It need not be proved that he or she is a legal guardian, or there need not be any proof that they are the parents, and there need not be any written consent. So that is the thing that we have to understand. But only one exception is POXO reporting. It is still needed, but we cannot deny the abortion services, because this is again to provide bias-free services without judgment, and this is a vulnerable group which needs your services and abortion care. 30-year-old woman recently widowed. Again, Dr. Shailaja was telling about a divorcee who wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. What is the answer you feel? Is it yes or no?
Mostly it's no.
Yeah. So it is no. So it is not our place or responsibility to tell her to continue this pregnancy. Again, a vulnerable group in the 20 to 24 weeks. So to end, again, in India, abortion is legal and our act is one of the most liberal, and let us make it safe and respectful. So Samarth Bharat, Sampurna Bharat. With this, I end my presentation. Sorry about the technical glitches and loss of that I missed. I had an internet interruption. Thank you.
Thank you, madam. Thank you,
Thank
Kiranmai, madam.
Yeah.
Yeah.
Thank you. The safety, the dignity, the respect, and the quality services should be given to the women who come for abortion to us. And the 4 tools of WHO, that engage, inform, explore, equip modules, we should look into it. And one thing I'm not able to digest is the accompanying person in a case of minor may not be a true friend or maybe a cheater. How to know about his authenticity? We cannot judge what type of person he is. So how can we take him into this thing?
Yeah, if she comes along with her said partner or boyfriend or whoever it is, if that person is an adult, then she cannot be denied, madam, as per the law.
Yeah, we cannot deny as per the law. Basically.
We have to document everything, but it is not our this thing to ask for a legal guardian or parent. That I'll do only if you get a parent.
And other thing is the consent form. Apart from the consent form, we have the other form like surgical procedure form or a medical termination form. We can as well take the signature of that person on that form that he is going to stay. At least that makes him to stay back there.
Previously, I was dragged into the court But not now, I think.
Yeah, I mean, it's not simple, madam. As you have said, we have to be very much well versed with the MTP this thing law and all its components. But again, we have to balance between safety and access and our own this thing safety also.
Yeah, as per safety, we can do it. But some other people, some from the village, the sarpanch and all, they come and why did you do it? That type of harassment was there for me long back, but not now.
For providing abortion.
Yes.
Even for
For a
me
minor.
also, ma'am, without husband consent, I did MTP for a girl, for a lady, and the whole village came with the husband. They did lot of ruckus in the hospital. So without my permission, how can you remove my baby? This is what they told me.
These are the limitations for us, the social limitations, not the legal limitations.
Yeah, now we are relaxed. We can do in a peaceful environment.
It is there to, it is coming to our rescue also in a way.
In fact, whatever has happened in the past is learning based
Yeah.
on which the new amendments of 2021 has come in.
Yes.
And this definitely is an improvement over what was happening in the past, and it certainly strengthens your hand.
Yeah.
Having said that, please do ensure that you protect yourself first,
True.
irrespective of what, without denying the service. So whatever is required in terms of documentation, Aadhaar card, age proof, relationship, parent, guardian, whatever, protect yourself first.
Yes.
Make sure all the documentation is in place before and at the same time, please do not deny the service, because the amendment very clearly and categorically states that service should not be denied irrespective. And if it is a case related to a minor, then of course POCSO reporting and all those procedures irrespective has to be followed, and the procedural aspect has to be put in place. I hope that clarifies.
Yeah, taking Aadhaar card and all, that is very
Yes.
good now.
Yes.
That will save us from
Yes.
going to the court.
Hello, Kiranmai.
Yes, ma'am.
Hello, I'm Dr. Sardar Unisa.
Yes, ma'am.
Very well done. I want little clarification on POSCO information because we are not doing it here. Can you just highlight on that?
Anybody less than 18 years, if they come with either history of sexual assault or even suspicion in your clinical examination or history or a pregnancy, you have to report, ma'am.
Go to the police.
We have to report, but how? Like, suppose we inform the police, it's become a big issue and all. So what is the other procedure to inform the police?
We have to sit down on the medical legal form and then send it, madam. There is no other procedure to say.
Yeah.
Medical legal form should be signed.
Yeah, MLC form, what we have like for in the trauma cases and all, same form we are supposed to fill, and then we have to send it to the police. And then take the initial of the police, then continue with the
form.
services.
The FIR should not be booked, but they just to give the information.
FIR coming to our purview, madam. FIR is like between the parties, not between the doctor and the.
Because we are in the knowledge of this abuse or assault or whatever is going on, and as healthcare providers, it falls upon us to inform. We
That's
cannot be silent about that.
Usually such cases are taken up by the government doctors. Usually they don't come to us. If they come,
If they come to you, you can't deny the case.
Okay.
That is also there now.
Okay.
Even medical boards, etc. also, it is not totally, though it is safer maybe to send to a government medical college, etc. But when they come to you, I don't think you can refuse.
Okay, thank you, Kiran.
Nice to meet you online. I think we have to move on maybe.
Yeah.
Next topic be Usha.
Thank you. Thank you, Dr. Kiranmai. It's a very interesting and elaborative lecture, and we all came to know many points. And now we can practice with little more confidence and little more peaceful environment. And now may I invite Dr. S. Satyaprabha, Professor of Gynec Department, Pratima Institute of Medical Sciences, to chair the session on the pre and post abortion and family counseling, family planning counseling, and leveraging technology for referrals and online consultations. Thank you.
Madam, we are not able to hear you, ma'am. Usha, ma'am.
Satyaprabha ma'am. Satyaprabha ma'am, Usha ma'am. Over to Satyaprabha ma'am. Usha ma'am. P. Usha Devi ma'am.
You're not audible.
Madam, can you hear me?
Yes, yes.
Yeah,
Now.
now.
Oh, thank you, thank you. Madam, you have to, the host has to enable me to share my screen. I'm not able to share my screen, madam.
Shriman, kindly check this now once. Shriman, are you there?
I made madam as host, madam.
Okay.
Is it visible, madam?
Yes, ma'am.
But not full screen, madam.
Yeah, full screen. I'm going for full screen. Is it okay?
No, madam. First you click on this enable editing button, madam. Which
Which
is
one?
here in the top. Enable editing. There's an yellow bar, right, at the top. Protected view.
Where is this, sir?
On the top bottom, I mean to say top on the top, madam, top side. There's a yellow bar, right?
Yellow bar.
Dr. Usha, below the red line, there is a white line. Below that, there is a yellow line showing enable editing. Below the topmost red line, there is a white line below that. Below that, there is a yellow line. On that, there is like enable editing. You have to click on that.
Enable editing.
Yeah. So below the red line, there is a white line. Below that is a yellow line. It shows enable editing.
No, I don't have any yellow line, madam.
Yellow,
I don't have any yellow line. You are able to see
at
my
the top,
screen.
At the top side, top, madam, on the top of the screen.
On the top, there is a yellow line.
You're able to see.
You are able to see, ma'am?
Yes.
Madam, it is.
Go ahead.
Actually, the cursor is on the red line now. You just come down, madam. A little bit down. There is a yellow line. Yeah. A little bit above. A little bit above.
Little bit above.
Madam, on the Foxy logo, just above that, there is a yellow line and enable editing. On the Foxy logo, you can see the
Foxy logo. Yes, this one?
No, this one. The Foxy logo is different. That is WHO logo. Foxy logo.
Yeah.
Yeah. Here.
There is a yellow.
Oh.
That is the one you are supposed to click.
Yeah, sorry. Is it okay now, ma'am?
Madam, it's not in full screen, madam.
Make it full screen, ma'am.
Now it is full screen.
No, ma'am.
It is not full screen, ma'am.
No, for me, this is full screen only.
Madam, maybe you can continue with this.
Madam, are you able to see my slides?
Yeah, it is not in the slides, slide screen. The total screen is not shown up, but can you just go down a little bit? Just we'll see how it goes.
It is okay. You can go ahead.
For them, it is not full screen.
You can just scroll
Madam,
down.
actually, for me, this is full screen.
That's why you just go down, madam. We'll see whether the slides are changing or not.
Ma'am, how you? I'm changing the slides. I'm coming down,
Being
scrolling down.
They're not being changed. You have to close and then again open, reopen.
Close and again reopen.
Yeah.
Oh,
Yeah, now the third slide has come up, ma'am.
okay. Now I'll continue like this, ma'am.
No, no.
Otherwise,
You have to log it. I think you have to start the PPT again, ma'am. Share the screen, basically.
full screen.
Make it full screen, ma'am. Yeah. You have to click on that, ma'am. Yeah.
Yeah. Is it full screen, ma'am, for you?
No, ma'am. No, it is not so.
It's not full screen for them.
Maybe you can continue.
Yeah,
For
I
us, it
think
is full
you can
screen.
continue. You can keep going page down and continue because.
No, I'll
Okay.
continue like this. I'm Dr. Usha from Visakhapatnam. I'm working in Andhra Medical College, Visakhapatnam as a faculty. I profusely thank WHO and FOXI for making me part of this great program. So this counseling is very important for respectful abortion care. Without counseling, RAC is not complete. And this is a cornerstone of RAC. What is counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts and feelings and perceptions. And this counseling is throughout. It's a counseling should be before and during and after the procedure of MTP. It's not a one-time procedure, but it has to start from the first visit and has to continue before and during and after the procedure is over. So the components of pre and post abortion counseling, it is an integral part of comprehensive abortion services, and it's an important as the procedure. Women may need help in decision making because she is totally ignorant. We have to make her aware of all the different choices and how they work and what is that suits her. She may be ignorant and may choose one option that may not be suitable for her. So she should be made aware that what is best for her. And wherever needed, the spouse also should be made a unit in while counseling.
Madam, the slides are not moving, madam.
Slides are not moving. I think there is a problem with my laptop.
And probably, maybe Shriman.
Madam, 1 minute.
Yeah. Now it is seen, ma'am. Now it is seen.
Now we can see, ma'am.
Now you can see, ma'am.
Yeah.
Is it full screen? Is it full screen?
It's full screen, ma'am. You can go ahead.
Okay. Yeah. So during the pre-procedure counseling, there are 3 helps and 1 ensure. We have to help the woman decide about the termination of the pregnancy. So while counseling this termination of the pregnancy, we have to talk to her why she has opted for termination of pregnancy. And in case if she has already decided for termination of the pregnancy, look at her fitness, whether she is fits into the criteria and examination part, and completely is this procedure suitable for her? So help her in deciding, in making the decision. And next, help the woman to choose the method of termination. And this is also again, if the method that is not suitable for her that she has chosen, we have to help her in choosing the method and also explain her in detail about the method and its complications. None of that methods are not without any complications. So she has to be aware that all the procedural and also the complications of the procedure. So whatever safe the procedure is. And next, ensure the delivery of complete information about the procedure and help the woman to adopt a contraceptive method once the procedure is over. And during the pre-procedure counseling, ensure privacy and confidentiality, as all my previous speakers have been talking about this. This is a very important part in the respectful abortion care. And be non-judgmental and be sensitive. So you should not pass a comments that how many number of times she'll come for abortion, and but make her aware that abortion is not a idea for implementing the spacing between the children. This is not the method of spacing between the children. So she has to go for other spacing techniques like contraception methods. And establish a rapport, not only talking about the medical problem and answering her questions, but also at the same time, you can go slightly beyond the box so that talking about her personal issues may make her feel free to open up her feelings. So then she'll definitely listen to whatever you say. Use a simple language and allow the woman to clarify her doubts. And she has to make up her mind for termination of her pregnancy and assess her for the procedure. So that is the clinical, including clinical examination and identifying any other medical concerns. And there is a relevance of counseling with the MTP. What is the relevance? Why this counseling of contraception is required during while catering this MTP services? Because there are some concerns with the while implementing the procedure. That is, there is a quick return of fertility. After first trimester, fertility will return within 2 weeks. After second trimester, fertility will return within 4 weeks. So she has to know these facts. Then she may be in a position to adopt a contraception procedure. And this is an opportunity for talking about the contraception acceptance. And minimum 6 months gap before the next pregnancy is required to recoup her physically and also mentally to be ready for the next pregnancy. And health benefits and better future pregnancy outcomes are also good if she can adopt a contraception method. And 90% of abortion related maternal mortality can be prevented by ensuring contraception. So prevention is better than cure. So contraception is always a preceding procedure before going for MTP, that we all know. So even we have to make her also realize that. Pre-abortion family planning counseling. So when to start and what to counsel. From the first visit and first consultation itself, we have to start the family planning counseling. But if she has any grief or any, she's crying, at that time we cannot speak about the, we cannot counsel regarding the contraception. So depending upon the timing, we have to start the counseling of contraception from the first visit itself. So during our counseling, what all the things to be counseled? Return of fertility that I already spoke. Help with choices. So there are multiple choices are there. They are in the government setup. They are all free of cost. She should know that. Break the barrier, because they're on their own. They don't want to talk about this contraception advice. In my experience, when people come with the LCB 1 year and again second time pregnant, I ask them why you did not use contraception. She never answers because she doesn't know anything. Sometimes people with LCB 5 years and second time pregnant. Then if I ask, what is the contraception that you have used for this spacing? She immediately says, no, I did not use any contraception. So she thinks that is a crime using a contraception, or it's a stigma. So she should feel that it's not a stigma. Only clever people and learned people only will use the contraception. So she should be aware of multiple choices of the contraception in the government setup and also in the private setup. But in the government setup, they all come with free of cost. Method specific counseling. So whatever the contraception that she choose, all the pros and cons, how it works, and how long the contraception can be adopted. Any interference with the soon after the stopping the contraception, whether the fertility will resume back, all these things have to be answered. And high risk behavior have to be, wherever there is applicable, have to be dealt properly. If a woman is not willing for any contraception method, then what to do? So we all know the answer, that don't refuse MTP. We can avail her next visit. Take the opportunity of the next visit to counsel regarding the contraception again and again. Counseling again and again. That is the only choice. Assessing suitability for post-abortion contraception. So soon after MTP procedure, so we have to think about few things, whether it's abortion is complete, or there is any infection in the post-abortal period, or any injury to the genital organs, or chances of fresh pregnancy. In case if she comes after 1 month, there may be chance of the fresh pregnancy, or if she doesn't get period within in scheduled time, then pregnancy has to be ruled out. Then only we have to talk about the contraception. And during post-procedure counseling, ensure women whether she understood properly all the precautions and care needed during the post-abortion period. And we have to take this opportunity to counsel for contraception in case not previously accepted. And this follow-up visit also reinforces the need for continuing the use of the contraception method if chosen already. And post-procedure, during this post-procedure counseling, she has to continue, we have to continue ensure privacy and confidentiality, and reassure her in case of any problems, and repeat the information about the post-procedure care and also danger signs. That is already dealt by my previous speakers. And post-procedure, post-abortion family planning counseling. If already she opted for a one choice of family counseling, choice of family planning method, temporary family planning method. So what we have to do, we have to appreciate. And also, if depending upon the family planning method that is chosen, IUCD or dipomethylhydroxyprogesterone acetate or OCS, the immediate care in case of IUCD is kept. She may require antibiotic, she may not, the dilemma has to be cleared, that what all the things that she required, or she has to come for a revisit, how soon she has to come for review. So all these things have to be cleared. And similarly for the oral pills, combined oral contraceptive pills, and also follow-up protocol. So when she should come to us again next time, depending upon the choice of the contraception. And reproductive infusion in continuity has to be spoken to her. If she has not decided, what is the reason for not taking any decision for this contraception? She may be having anxiety, so it's our duty to allay her anxiety by counseling and properly telling her all the benefits of this contraception. So benefits, not only contraceptive benefits, but also non-contraceptive benefits. In case if she is having heavy bleeding during period, so contraception like contraceptive pills, combined with contraceptive pills, may be of more suitable with a dual benefit than going for intrauterine device. And importance of immediate adoption and chosen, extended period of adoption, and couple counseling. Couple as a unit, if possible, have to be counseled regarding the contraception, so that may yield a better result. And also emergency contraceptive pills. So she has to also know, in case she is not adopting any contraceptive procedure, then there is also a choice of emergency contraceptive pill, but not for repeated use, only for emergency use. And quickly, I will take you through different methods of the post-abortion contraceptive methods, when to start, what are the different choices, and when to start. Condoms, as soon as sexual activity is resumed after the first trimester and also after the second trimester abortion, it's better to have abstinence for till at least the bleeding is stopped. And additional information regarding the condoms: it doesn't have any hormonal side effects, can be used without consulting health worker, easily available, and male partner is also actively involved. And it also has a prevention aspect against sexually transmitted infections, including HIV. And other contraceptive choices like intrauterine contraceptive device, IUCD 380A, IUCD 375, that will have a duration of 5 to 10 years. It can be inserted immediately after the first trimester and second trimester abortion up to 12 days, from immediate to 12 days after first trimester and second trimester abortion, provided the first trimester abortion is surgically done. But in case if the first trimester abortion is done by the medical method, then we have to wait for the next period, because she'll have bleeding for up to 13 days. So it's better to wait for next period, and can be we can go for the IUCD after the next period. Till then, they can go for the barrier methods. And also we have to confirm that no products of conception are uterus is empty before putting this intrauterine contraceptive device. At the same time, contraindications have to be ruled out, like maybe she is having menorrhagic cycles or in post-procedural infection have to be ruled out. And coming to the efficacy of IUCD, it's highly effective, almost close to 100% efficacy, just like oral contraceptive pills. It provides long-term contraceptive. She doesn't have to remember daily and take a pill. So once it is kept inside, it will be there for 5 to 10 years. It will work for 5 to 10 years, depending upon the contraceptive property that we are using. Can be provided by the trained doctors and also trained ANMs. After medical methods and by PPICD trained doctors after second trimester abortions. So the PPICD that is kept soon after delivery. So just like the PPICD, we can go for intrauterine contraceptive device soon after the second trimester abortion. It doesn't have any interference with the sex and immediate return of fertility soon after removal. That has to be reiterated. And next contraception, hormonal contraception. Long-acting depot injections like dipomedroxyprogesterone acetate, 150 milligrams every 3 months. It can be used up to 2 years, taking IM injections every three months. And it can be started from the up to 7 days after surgical method of abortion of first trimester, and after second trimester also up to 7 days immediately, starting from soon after the abortion. But when it comes to the medical methods, if MMA is followed for first trimester abortion, it has to be started from 3rd day. That may coincide with the misoprostol tablet. And other information, other advantages of depot injections are it's highly effective, confidentiality and privacy is maintained, can be provided by doctors and also trained nurses. A doctor, if give first injection, that's always better. No interference with the sex, no effect on the quality and quantity of the breast milk. So being a progesterone agent, it doesn't interfere. It can be given for the lactating women also, and no estrogenic side effects. It offers protection against ectopic pregnancy, ovarian cancer, iron deficiency anemia, and uterine fibroids. As the periods may be number of periods may reduce. She may go for amenorrhea also after second or third injection. But sometimes she may be having spotting, occasional spotting or irregular bleeding. That has to be told her. That will be within first 3 to 6 months. And coming to the permanent sterilization, there are two options, for one for female and one for male. When it comes to the female sterilization, can be performed after an abortion in the absence of any infection or severe blood loss if she is fit physically, that is with good hemoglobin content, concurrently or up to 7 days after the first trimester abortion. But mini-lap cannot be done after the first trimester. Mini-lap and both laparoscopic sterilization can be done after the first trimester abortion if it is a surgical. But with medical methods of abortion, mini-lap has to be postponed till the next menstrual cycle. Whereas after the second trimester abortion, it can be done, taken up immediately up to 7 days. If there are no contraindications. And female sterilization is a permanent method of contraception. It's highly effective immediately, and no interference with the sex, no effect on breastfeeding, no long-term side effects, offers protection against ovarian cancer. Vasectomy is performed in males independent of timing. This can be taken up at any time. But one caution for the couple, those who take up this vasectomy, though this is very effective, they must use some other contraception for 3 months after vasectomy. It's a permanent contraceptive method for men. But there are so many myths and misconceptions about the vasectomy regarding it will cause impotency in men and they will lose their strength. So all these misconceptions have to be dealt and they should be made aware of the facts before going for vasectomy. In our country, as it is, vasectomy rates are very less, and they have to be, once their proper health education is given, even in future vasectomy rates may increase. And this is the timing of different methods of contraception. Combined oral contraceptive pills can be started immediately, that is from the 3rd day, may coincide with the misoprostol tablet. And injection medroxyprogesterone acetate also similarly can be started immediately after the first trimester and also after the second trimester. Centroman is a non-steroidal contraceptive. It's an anti-estrogenic. That can be also, just like other hormonal agents, can be started immediately from the 3rd day. And the intrauterine device can be kept soon after the surgical MTP for the first trimester and also for second trimester MTP. And tubal ligation can be taken up as I discussed in the previous slides. And contraceptive methods with vacuum aspiration, that is nothing but the surgical method of abortion for the first trimester. After the surgical method of first trimester abortion, oral contraceptives can be given immediately. Injections can be given immediately. Centroman can be given immediately, and IUCD also can be inserted immediately. So tubal ligation also can be given. So all the methods can be given soon after the surgical method of the first trimester of abortion. And this teleconsultation and other technology in the delivery of the healthcare system, with the COVID especially, we even a common man understood very well the advantage of this delivering technology and service provision in the form of telepathy, teleconsultation, teleguidance, telereference, and telelinkage. So we can take the help of this teleconsultation. It will have so many advantages. And for knowing the information, IEC material is available on the website. and also social media. Ask Tanu is one app, and by YouTube, if you ask whatever question, the contraceptive advice is given by Ask Tanu app, and infographics, helpline, and other patient education platforms like WHO, Ministry of Health and Family Welfare, RCOG. So you have ample of options for knowing the information in the internet. And SWOT of teleconsultation: strength, weakness, opportunity, and threat. So what are the problems? What are the advantages? When there are advantages, there are at the same time also there will be some disadvantages. The strength of this teleconsultation is understood by everyone during COVID era. Last 2 years, we have been mostly depending on this teleconsultation, and government also approved teleconsultation as a amicable solution for as a substitute for physical consultation wherever it is possible, and it's approachable throughout the process, and confidentiality also is maintained. At the same time, even in rural area, you can reach the rural area women also can get benefited by this teleconsultation. And awareness about the spread out questions and answered at ease. The weakness of this teleconsultation is the face-to-face consultation is lacking. Sometimes it requires to talk face-to-face, as everything cannot be discussed virtually. And demonstration, if some method has to be demonstrated, demonstration cannot be done by teleconsultation. So in that case, she has to come physically for the consultation. And we can also take this opportunity for privacy, cost saving, and number of visits can be cut down. And there is one threat with this teleconsultation, that is missed opportunity and misdiagnosis. Occasionally we may miss a diagnosis because physical examination is lacking. Applicability of the components of the CAT training: the assessment, confirm the diagnosis and contraceptive that is used, counseling via Zoom or video conference, and follow up. These hybrid services can be utilized. It is always better to cut down the number of visits, and in the place of physical consultation, we can also avail virtual consultation. So hybrid services can be offered. For example, MMA requires 3 visits: first visit, third day visit, and 15th day visit. So this third day visit can be cut short. That can be done by teleservice, and also she can stay at home and take the misoprostol tablets. So number of visits can be cut down, or tele and physical consultations can be combined. The key messages in this talk: realize the need for post-abortal family planning, bring the couple on board and strive for 100% coverage. The 100% always may not be possible for this, especially this kind of issues, but at least we have to strive for 100% coverage. Capitalize the basket and applicability of the post-abortion period, and technology as far as possible has to be used for scope for entry in the CAT services, and concern the policy, malpractice, and service costs and access should be also we should show concern regarding this policy, malpractice, service costs and access. And adolescent reproductive health needs, both online and offline. This is again a hybrid consultation can be offered. So we are very happy and we are very lucky that in India, abortion is legal, and we have to try for a safe and respectable abortion services. all of us together, all the healthcare service providers. Thank you very much for giving me this opportunity. Any questions?
Madam, I would like to ask.
Yeah, please.
Yes,
Can you hear me?
Yes, yes. Actually, it's a question, ma'am. In India, abortion is legal, but
Yes.
still sex selection abortion is illegal. But
Yes.
sometimes patients at their gestation age of 16 weeks or 14 weeks or 18 weeks, they may go to quack or somewhere and they may get to know regarding the sex, and they will be coming to us as a conception failure or unplanned, unintended, unwanted pregnancy. If the already 2 female children are there, that the third pregnancy, if they come as that in that manner, how we should proceed, ma'am? Whether we should go for abortion or whether we should deny.
See, it's a complex, what you have asked, there are multiple questions in that question. Actually, when they go for a MTP services to a untrained person or a quack, automatically that comes under illegal. And not only that, when they see, our concern is after their first visit to us. So when they come to us, the situation, the clinical situation, if it is an incomplete abortion, then it doesn't come under MTP Act, first of all. So we have to take normal consent, not the MTP forms. Have to MTP forms, form 1, 2, 3, they need not be filled. We'll take it as a normal any other procedure.
No, ma'am, what I asked.
So actually they're asking whether if they have come after the sex selection has been done, what to do, right?
Yeah, that is one more question. That was also asked by Dr. Satyaprabha. If they came to us with sex selection, after sex selection, and they want MTP. So how do we know that they came for they knew sex selection already? Unless they tell us.
No, ma'am, and sometimes if the gestation age is 16 to 18 weeks, 2 female childs, then we can
guess.
Get to know from their attitude and their words.
Yeah, we can guess to some extent.
Yes.
Answer basically in the PCPNDT Act form, what we form F, what we fill and send. They each and everything is like we have to submit to them. Which pregnancy, before it is a male child, it is a female child, we are supposed to enclose the Aadhaar, their phone number, contact number, everything.
Yes,
so if the government has a little clue that something is going wrong, they can definitely just click on their Aadhaar, see whether PCPNDT Act, like a Form F has been submitted, then they have delivered, and all this can be done. So whoever does the sex selection is really at the problem. All the scans are being updated, right?
Yes, ma'am.
So there lies the crux. So if the patient goes for a scan and then immediately goes for an MTP, everything is going into the government hands, right?
Yes,
if they have a little bit of a clue, then whoever has done the sex selection is at a problem.
Okay. Yes,
one thing is that. Second thing is, when they come for an abortion service, we have to do the abortion, like we have to complete the process. Otherwise, they go for a unsafe abortion. So try to counsel her, talk to her, like, and then if it is like really a previous to cesareans, inform her all about all the complications, like she may need an hysterectomy. And the next time if she continues, it can be again a scar pregnancy, all these problems, discuss her, little bit scare her also, and then maybe she denies it and continues the pregnancy. But still it is our responsibility to talk to her, fill all the forms, and then proceed with the abortion. But try to counsel.
That is one thing, and again, if they come for MTP with third gravida, 16 to 18 weeks period of gestation, then MTP can be followed by permanent sterilization. That further they have to agree before we offering them MTP services.
Yeah, that is true. That is always true.
Yes, thank you, ma'am.
Thank you, ma'am, for elaborate lecture on counseling and family planning advice. So many people are ignorant, and And first of all, when we advise contraception like IUCD or oral contraceptive pills, they immediately ask that, Madam, are there any side effects? So we should give some time so that we'll counsel and make them select a proper family planning method. Madam, thank you.
Madam, one
Shivani
more
madam.
doubt. One doubt, ma'am.
Tell me, ma'am.
After first trimester abortion and after second trimester abortion, when is the couple allowed to go for intercourse? Because this is the common question everybody asks.
So unless they follow a contraception within 14 days, again she can become pregnant, madam.
After first trimester, she can ovulate within 2 weeks. After second trimester abortion, she will ovulate within 4 weeks. So she has to they follow abstinence till the bleeding stops. That is first thing. And if contraception like intrauterine device is not kept soon after the surgical MTP of the first trimester and soon after the second trimester MTP, then they have to follow barrier methods after stopping the bleeding.
Madam, if they are not interested to follow a contraception, then it is probably whenever they are comfortable. That is immediately the bleeding stops. Otherwise, if they want to like go for a contraception, it is like till they start the contraceptive.
That's what counseling. That is the only mantra that we have.
Yeah, in a lighter vein, I would like to share some of my experiences previously, because since from childhood, my deeply embedded feeling is Brunahatya Mahapapam. Brunahatya Mahapapam. So I keep on telling my patients to continue the pregnancy. I always go with the prevention is better than cure. So I tell my patients to continue the pregnancy, and most of the children, they are 10-year-old, 15-year-old. When I encouraged for pregnancy and not for abortion. Now the abortion is respectful, then now I need not tell them to continue pregnancy. I will straight away go for.
No, ma'am, it is our responsibility also to tell them what are the pros, cons, whether she can continue or not. But definitely it is their decision. We need to counsel them because they come with a small reason saying that I have so many goals in the job and all these things. Being 30 years also, they want to postpone their pregnancy. At that time, we need to counsel that regarding that fertility and all also. So it depends like on us also the responsibility to talk to them, to explain about the fertility and what are like really whether when they have to plan, what is the preconceptional counseling, everything we need to do, ma'am. Or not only if they ask, it is not like that we just jump and do that. We need to do so much of counseling. Yeah.
Actually, in India, we are lagging back. We are lagging behind very much, madam, regarding this planned pregnancy. So people, they don't have the concept of planned pregnancy even in the educated strata. When I am providing MTP services for the whatever reason, maybe though it's a valid reason, I have that pinch that we are doing that Bruna Hatya kind of thing, going against God's wish. But see, I have seen patients who are going to a quack for these services where it's not accessible, or confidentiality they don't want to go, or financial constraints are there. They come with lots and lots of permanent complications. Very big complications. They have come to the tertiary referral center. After seeing that, I feel providing this contraception, providing MTP services is far better than leaving them so that they'll go to a quack.
So,
but we should confront to our law.
So take home message is just counsel them to have the pregnancy continue, and we educate them. Prevention is better than cure, and then
continue if they have one child, and but if they have already 2 children, and it's a financially also they are not sound enough to bring up 3 children, then probably we have to offer services rather than counseling them to continue the pregnancy.
Mm.
That's what I feel.
Yeah. So nice of you, ma'am. Osha, ma'am.
Thank you so much, Dr.
Sushila,
Sarija, ma'am.
Yeah. Sushila, ma'am.
Thank you.
Usha, ma'am, and Kiran, my ma'am. We are very happy to hear you. And on behalf of Karimnagar Obstetric and Gynecology Society, I'm Dr. Akula Shailaja, President of Karimnagar Obstetrics and Gynecology Society, Dr. Manasa, Secretary. We thank you once again, ma'am. Thank you very much.
Ma'am, one point, if I heard correct, Kiranmai madam telling that if a girl less than 18 years comes for MTP services, whoever is accompanying her, adults whoever accompanying her, not the guardian or parent, they don't have to sign the consent form.
Yeah, they need not sign.
Consent form signature is not required. Is it true?
See, Form C, if she is a minor, whoever is supporting her has to sign, madam. If she is less than.
That is consent form. Form C is consent form.
See,
that has to be signed by the accompanying person.
Accompany. If she is more than 18, only she has to sign.
Yeah. If she's more than 18, no controversy.
You need to inform the police, writing on the MLC form. We have to give them, take the acknowledgement, then proceed.
That's what becomes an MLC.
Yeah. Once they sign, we have to proceed. Otherwise, we cannot proceed.
Correct. Okay. Thank you.
Okay, ma'am. Thank you, ma'am.
Yeah.
Thank you so much. I think we have come to the end of the session for today.
Thank you, Mansa. Thank you, Shaljama. It was really a wonderful interaction to say rather than just a talk. Thank you so much.
Thank you.
Please do all, after leaving, you'll get one column as a continue. Please press the continue button so that you'll go through the post test and feedback. Then only you'll get the certificate. Please, otherwise in the chat box, you have the link Shriman has shared. Just go to the link.
Ma'am, this question of a below 18 years girl when accompanied by, like when she comes for MTP services, guardian or parent has to be accompanied. That question looks very tricky. Even I put wrong answer when I attended for the first time training.
Yes, ma'am. Yes. Actually, as per new law, is one no need of legal guardian or parent. Any guardian more than 18 years, they can give consent.
Someone should be required. That's what I felt. No one. If I put like yes answer,
Obviously,
is
boyfriend will come, madam.
The answer is actually
boyfriend
no. But I put yes. If I put no answer, I thought nobody is required.
Obviously, boyfriend will come.
Yes, ma'am. Yes, ma'am. But provided you should be above 18 years. Boyfriend should be above 18, ma'am, or above 21?
Boys, above
Boyfriend,
18, above 18 is adult and he has got voting. He can
eligibility. Yes.
Yes.
So above 18, boyfriend is enough. 18. Okay, madam. Thank you. Thank you so much, madam.
Thank you, ma'am.
Thank you for giving me this opportunity.
Yes, ma'am. Thank you. Please, all of you, please kindly go to the post test and feedback for the certificate. After you press the leave meeting, you'll get two options, continue or exit. Please press the continue option so that you'll go to the post test and feedback. Please don't miss this. If at all someone misses the post test, kindly contact me. I'll send the link. Thank you, everyone.
Okay, Manasa. Bye.
Thank you, ma'am.
Bye,
everyone. Bye.
Manasa ma'am, if they just click on the link, they can redirect to the process and feedback, madam.
Okay.
They no need to be on the meeting.
Okay.
They can leave the meeting and they can fill and submit.
Okay. Thank you, Shriman.
Welcome, ma'am.
Yeah.
Thank you, Shriman.
Who are there now? Actually, you can go to the link in the chat box directly. You'll direct it to the post test. Rani ma'am, Manasa, Chandramati ma'am, Shruti, Chandana, Swapna, Manasa, Priyanka, Kavita ma'am, Deepika. Kindly go to the link in the chat box So you'll be directly directed to the post-test and feedback. Thank you, Shalja madam.
Bye, Manasa.
Yeah, ma'am. So many clarity. Ochina, ma'am, in 2 cases, anemia and that divorce.
Rale, patient rale.
I mean, we got clarification. Anemia, we should not deny, and even divorce also we should not deny.
Yeah.
Yes, ma'am. Thank you, ma'am.
Okay, bye. Bye.